Thanks so much for joining us tonight. I will get started by acknowledging the support from Philips again. I've been playing with their machines, and it's interesting to see what kind of pictures you can get on the different machines and at what price point and stuff. So I've got a couple of machines sitting at home now. We've pretty much moved most of the office from the office, all the teaching material to the house so that we can keep going. But anyway, tonight's topic, as Brian suggested, the acute scrotum. So thanks for that, Brian. It's a good topic to start with, and it's given me the impetus to renovate our scrotal talk. So when your patient's presenting with acute groin pain, there's lots of things that it can be, and a couple of things that we really need to differentiate is it torsion of the testes or is it orchitis? Most of the cases of testicular torsion are either spontaneous or maybe after some sort of minor incidental trauma, but there's an onset of severe testicular pain that's not relieved by elevating the scrotum. Usually for torsion, there shouldn't be any fever or urethral discharge, but it's often said time is testicle. So there are signs of testicular hemorrhage and infarction appearing within 2 hours of the testicular artery occlusion, and irreversible ischemia after 6 hours. So it's really important to get onto that diagnosis as early as possible so that you can reduce the time to definitive surgical management. Mostly this is a clinical decision, but every now and then you might need to, check and use other tools to help you differentiate, is it torsion or is it epididymitis? And the challenge with that is that both of those presentations present with similar signs. So scrotal pain, swelling, redness or tenderness, and there's other things that are in common in the clinical presentation. So the goals of ultrasound are to help make that differential diagnosis, and we want to assess the size of the testes, we want to look at the structure, look at the echo texture, and assess the vascularity. So I thought we'd start by just refreshing some of the anatomy and then look at the scan technique, look at some of the sonographic signatures for some of those pathological conditions that commonly present, and last but not least, some practical troubleshooting tips. So if we start with the anatomy, the adult testicle is an ovoid structure. It's about 3 centimeters wide. It can be 2 to 4 centimeters thick and 3 to 5 centimeters in length. The size of the testis will decrease with age. You can see in this image here from the mediastinum testis there that there are several radiating septa that extend into the testis that have those lobules, and each has their blood supply. The reti testis is the network of delicate tubules that are located in the hilum of the testis and out through those lobules that carry sperm to the seminiferous tubules and to the efferent ducts. If we look at the epididymis, it sits on the sort of north pole of the testicle. The total length of the epididymis is usually about 6 centimeters long, but it's so tightly coiled. If you unraveled that whole network of tiny little tubules and stuff, it can be up to 6 meters long. So the head of the epididymis is the largest and most prominent part, and it's found at the superior pole of the testis, with the tail sort of out laterally and inferiorly along the testis. The head of the epididymis measures about 5 to 12 millimeters in length, and sometimes, every now and then, I haven't seen too many myself, but sometimes you can see a tiny little appendix testis. So if we look at the ultrasound pictures here, you can see in the longitudinal image, it's oval in shape, and in the transverse image, it should be round in shape. They're equally homogeneous the whole way through the testes, and it's mid-level echo texture or mid-level echo. So similar to the shade of grey that you see in liver, and it should be really smooth and consistent throughout the whole testis. Here we can see the epididymis, and it's positioning at the north pole of the testis there. And if you kind of think of, you know, the way that we're presenting the images in the long with the head left of screen, you can see that that epididymis sits on the North Pole. We have the head of the epididymis, so our probe is about here. And then when we look for the tail, you can see this hypoechoic. Can you see my arrow there, by the way? Yeah, you can see this sort of hypoechoic area here. So you find the head of the epididymis and then move your probe slightly, you know, towards the lateral border, and then, you know, swivel your probe just a smidge until you start to see this sort of hypoechoic band of tissue, and it almost looks like little tubules in there as well. So we're putting our probes that are over here to find that the tail of the epididymis there. Now, every now and then, a lot of people do have this bright white echogenic sort of strip here, and that's the mediastinum testis. So if we look back at this sort of anatomical diagram, you can see at the hilum of the testis there, you've got this sort of band of echogenic bright tissue, and it's a network of fibrous connective tissue. It's wider at the top than it is below, and there's a number of imperfect sort of septa coming off from this mediastinum. And if you picture those septae there, when you see like a hyperinflamed and hypervascular testis, you'll see that the blood vessels sort of follow that kind of pattern and radiate towards the surface of the testis. I kind of think of that mediastinum testis is like the train station, and the reti testis is like the trains going through the train station. So the reti testis are the tubules that pass through the mediastinum testis. So you can see where the probe is here that would demonstrate the mediastinum testis, and you can see that very bright echogenic linear sort of line through the testis in the longitudinal orientation. Have a look here at the, sorry, there we are. Have a look here at the other thing you need to think about is looking at the scrotal skin thickness. So we have here normal testis, and it's very thin skin, and that's completely normal. But in a lot of pathological conditions, you'll see that the skin is quite thickened. And the other thing to be wary of is, hang on. The other thing to be wary of is when your patient is very cold and exposed, the thin also gets thick and quite corrugated. And so you can see here, this is a normal testis, but very cold, and you can see sort of the wrinkly skin here, and that dartos muscle has just shrunk and contracted, and so it artificially kind of thickens here the scrotal skin thickness. So there's some signs to look for what's in a normal testis. So let's have a look at the scan technique. The first step is to choose the right probe for the job. So the linear probe is, of course, the best probe. It's high frequency, very good for near the surface. Now the testicle is only about 3 or 4 centimeters wide, and so the linear probe is good for that near field resolution. The problem is that the width of the footprint here, a lot of the time the adult male testis is just doesn't quite fit within the length of the probe. And so you do need to sort of keep the curved probe on standby. And it's good for getting a whole overview of it and being able to see both poles of the testis in its true length to be able to make a measurement. But the detail on the curved probe, because it's lower frequency, is not that great. So choose the right probe for the job. You want to set your preset, so use a, if your machine has a testes preset, use that. Otherwise, small parts or an MSK or something that's sort of a superficial setting. And last but not least, you need to think of how your patient is positioned, and we'll get to that in a moment. So I just wanted to show you the difference here between the resolution of the linear probe versus the curved probe. And you can see that the testis doesn't quite fit within the footprint. We're just losing a little bit of the upper and lower pole here. Whereas on this curve probe, you get both ends. But the definition on this curve probe is not that great. So it's great for measuring the length, and that's about it. When you are positioning your patient, there's lots of different sorts of theories or ideas around how to position. I've heard everything from put a face mask under the scrotum to support it. Face masks are a bit light on the ground at the moment, so perhaps keep them up your sleeve for more important things. I was taught originally to drag a towel up and catch the penis as you sort of drag that towel up, and then tuck it under their backside so that then the scrotum is exposed. I have to say I had so much trouble with that because the penis just keeps getting in the road and falling in the road, and it becomes a problem. So the way that I position my patients is to just ask them to, I cover them with a towel, I ask them to reach under the towel and to hold their penis, and if they put their penis on their lower abdomen like so, then you can, it pulls the scrotum out a little bit and keeps the testicles sort of nesting in the legs there. So it keeps them up and out of the road, and I found that to be much more helpful than towels or supporting towels underneath or whatever. It also doesn't require a whole lot of extra paraphernalia. I start the examination with just putting my probe in a transverse orientation. Now, sometimes depending on the lie of the testes, it might be a little bit oblique, but I'm just trying to get a picture of both the left and right testis on the screen. What I need to do at this point is to compare the size of each testis to make sure they're about the same size, and looking at the echotexture. Here's an example of, on the right side is to have the testis is a little enlarged, and on the left side it's normal. And here's an example where you can see the echotexture of the right testis is a little bit hypoechoic in comparison to the left testis there. The next thing to have a look at is to compare the vascularity. So in that same position, I pop the color Doppler on, and I'm trying to, again, compare the vascularity of the left and the right testis. So you can see on this image here, on the right side, there's a normal amount of flow, and on the left testis, it's hypervascular. And on this side, we have the right testis that has no flow within it, and the left testis showing normal vascularity. So you can see how it starts to show the difference with that comparison. So then we get busy actually scanning the structure of the testis itself. So I like to start on the normal or the unaffected side first. This gives me a benchmark for echogenicity, for the texture, and you know what it should be like. You need to then adjust your probe so that you orientate yourself to the longitudinal axis of the testis, which might be straight up and down, it might be oblique, it depends how mobile the testis is. You know that you're in a true longitudinal position when the testis is really nice and oval in shape. And then what you need to do is scan from one lateral border to the other lateral border. As we scan through here from one side, it's nice and oval all the way through to the other side there. Rotate the probe then into the transverse orientation. So from wherever the longitudinal lie of the testis was, you need to just rotate the probe 90 degrees. And you can see we've got our probe marker sort of pointing more towards the patient's right side. And then you want to go from the inferior pole to the superior pole, or whichever way, but going from the top to the bottom, and make sure you just extend your scan a little bit further than the boundary of the testis. You know you're in a true transverse position when it's the shape of the testis stays round the whole way through that sweep. If your testis is not so round, you're probably obliquing a little bit. So you just need to rotate your probe a little to get into a true transverse orientation. When I go to look for the epididymis from that longitudinal image of the testis, I want to move my probe up to the North Pole, and then I'm just sweeping left and right to try to find where the epididymal head is. So sliding up and then sliding left and right to find where the epididymal head is. To find the epididymal tail, you need to rotate your probe a little bit to be able to lengthen out the tail of the epididymis, and then you search laterally and just start sweeping over towards the lateral border of the testis. So you can see here the epididymal head, and then we have this hypoechoic, so you can see the little tubules in amongst it there as well. I'll just play that again. As we come out, you can see that band of hypoechoic tissue here. At the end of everything, I do a quick measurement using the curved probe to get the true longitudinal measurement, and I can use the linear probe to find nice boundaries and the imaging for the transverse measurement. So as with the convention of measuring in anything, is in longitudinal we take a length and a depth, and then in transverse we take the width. Again, as you can see, there's a huge difference in the image quality here, and the linear probe being high frequency is going to give you much better imaging for the testis itself. So let's have a look at some of the pathologies that you can see. The first one is torsion of the testis, and here was where the question was. So detecting flow within the testis doesn't necessarily exclude the diagnosis of testicular torsion. It'd be nice and easy if everything was quite simple, but unfortunately you can get intermittent testicular torsion and get detorsion causing the intermittent pain and intermittent ischemia. Incomplete torsion is where there's some degree of torsion and of the cord, but the blood flow hasn't been completely occluded. The other problem that you can get as the testicle detorts is that then you can get a hypervascular response and a flooding of blood to sort of make up for the loss, I guess, and reflecting a reperfusion of the testis. So the things that we're looking for on ultrasound is to look for an enlarged testis. Now this is on B mode. Any altered echo texture, pop the color on, look for asymmetric flow, and then also look for some scrotal wall thickening. Sometimes you can have a reactive hydrocele with testicular torsion. So you can see on this image, this is a 13-year-old who had pain for 2 days. And just on this B mode image, I know something's up. We can see that there's quite a big discrepancy in the size of the testes here. And you can see that right testis is hypoechoic in comparison to the left testis. It's subtle, but it's not, it's definitely something's going on this right side. Another case here where you can see there's a difference on the right and left side in the amount of vascularity you can see in the testicle. You can see on this one, it's quite marked altered echo texture. So there's likely to be an infarct here, but you can also see the left and the right comparison of vascularity. And there's quite a big asymmetry in that vascular pattern. Here's another one on real time, and you just get no color flow. Now for me, this whole idea of putting color on requires that you have good knowledge of how to use the color Doppler. And you can get a no color or absent flow if you've got your Doppler settings wrong. So to just rely on a Doppler trace, I think is a little bit risky because if you don't know how to drive your machine well and how to set things up properly to optimize the flow for a low flow pattern, you could make an incorrect call. Here's a case where there's testicular torsion with preserved flow, and you can see on this video loop here that there's an evidence of a twisted cord or a whirlpool sign. So as the probe sweeps inferiorly over the cord to the testis, it's seen twisting through 360 degrees. And as we come back in the sweep, you can see that twist again. I'll just play that again. The whirlpool sign is pathognomonic of testicular torsion and requires an urgent intervention Now, in this particular case, you could still see colour flow on the power Doppler and on colour Doppler. And so it wasn't completely torsed.
Do we know, Suean, whether the other testicle, like there may be still flow on that side, but how did it compare to the flow on the other side?
I'm assuming that it was reduced, but I haven't got the other picture of that one, unfortunately, to show you.
Yeah.
I guess the thing is with testicular torsion and just relying on the blood flow is you need to set it up so that on the normal side, you can see some flow. I mean, I don't know how often, what the clinical incidence is where you've torted both testicles at the same time, but or how many people have only got one, so that you haven't got a comparison. But if you have a look at the normal testicle first and get your color settings set on the normal side before you then go and examine the abnormal side.
Yeah, that's what I usually do. What are your thoughts about using power Doppler versus color Doppler, and also looking at the waveform? Because, you know, obviously looking at the waveform starts to become more complex.
Power Doppler, absolutely. So the difference between color Doppler and power Doppler is the red and blue one that's giving you the directional information. And the power Doppler is counting, it's like counting the number of red blood cells circulating. So it's much, much more sensitive for low flow states. So when you've got, you know, the smaller the vessel is, so, you know, fingertips, intrarenal vessels are really difficult to see. Intratesticular vessels are very small vessels. So the smaller the vessel is, the more helpful that power Doppler is going to be. Again, you have to optimize the imaging. So a lot of the time, the first problem will be that you have your gain set incorrectly, and I'll go into that a little bit later. But if you haven't got your flow sensitivities set right, you will miss flow as well. So those flow sensitivities typically on a testicular scan will be less than 5, you know, at most 7. But if you've got your flow, your Doppler PRF set at 20, you're just not going to see flow in the testicle. So you want to have that PRF set below 5. I
try to use power Doppler, but obviously you got to try and get rid of all movement. If your hand's not perfectly steady or the patient's moving a bit, then power Doppler becomes a bit more challenging. But I try to use it.
And you raise a really good point here, because especially with novice users, and when you're just learning to do scrotal ultrasound, the hardest thing to do is to keep your hand still. And of course, the Doppler signal is giving you a Doppler spectrum for anything that moves. The idea is if your hand is still, the only thing moving is the blood flow past the probe, and so it codes that moving blood flow. But if you can't keep your hand still, then everything is color, and you're not going to be able to sort out what's color in a vessel versus what's color from your hand movement. And it's for that exact reason I've been looking, obviously, in preparation for tonight. I've just been reading a few of the papers, and there's a lot that talk about using RI values and stuff. I absolutely do not think that this is the place of a point of care scan. First of all, to get RI values and to get pulsed wave Doppler traces on such a small vessel requires really, really good probe skills. And so there's only a handful of people in the country who have enough skill to be able to do that, but then also know how to optimize the pulse wave Doppler trace as well. And so if you can't optimize the image well and you can't hold your hand still, the chances that your pulse wave Doppler trace are going to be anything useful are very slim. And I just don't think that is the purview of the point of care exam.
And even more so when you're dealing with the pediatric testis, where you've got a smaller target.
Yeah, and a wrigglier target. So the best thing that you can be doing is, and even if all you did was look at the B mode findings, you're looking at size, you're looking at the echo texture and the echogenicity, and yeah, pop the color on to compare the flow, but it's not the be all and end all, and it's not, I wouldn't be hanging your hat on it. I still think that your clinical skills are probably going to be much better at it than your color skills for a long, long time. So, you know, you don't want to go overcalling or undercalling and just hanging your hat on it on the Doppler scan, because I think it would be risky. The next thing that we want to have a look at is orchitis. So the classic features here is that it's hypervascular, enlarged testis, altered texture, and scrotal wall thickening. So, you know, all of those things can happen. The hypervascularity is in complete contrast to the properly torted testis. But if you've got a partially torted testis, or if it's reperfusing after detorsing, you can get hypervascularity in testicle torsion. So, but the other three signs here are very similar to what you see for the testicular torsion picture. And so again, it comes back to that clinical call on, you know, do they have a fever? That would probably differentiate, or it might have, the pain might have been a more gradual onset. So it relies on you taking a really good clinical history to help you to differentiate the two here. You can also get a reactive hydrocele for orchitis as well. So here's a case of a 24-year-old male who presents with 36 hours of right testicular pain. He's not a very good history person and can't remember much details about the exact onset of the pain, but he has risk factors for a sexually transmitted infection as well. His right testicle is swollen and tender, and so the clinical question is it torsion or epididymo-orchitis? Now on this picture, the right testicle shows hypervascularity in comparison to the left. So it typically would fit a orchitis picture. On this image, we have a transverse sweep from superior to inferior through the right testis using the power Doppler, and you can see it has a lot more sensitivity than and is much more obvious to see those vessels. You can see marked hypervascularity here. And as you're watching this clip, you can see how those testicular arteries actually sort of follow that you know, the segments pattern, if you remember from that first slide with the lobules of the testis. So on image 2, we have a longitudinal sweep across the testis. Again, you can see using the color Doppler, you can see the increased vascularity here, and the blood vessels following that sort of radiating pattern out to the surface. Same patient, we're comparing the right against the left, and the scale, the depth is equal on both sides here. And so, and the grayscale hasn't been changed either. So you can see here that the size of the right testis is bigger than the left testis, but also it's a little bit hypoechoic. It's subtle, but it is a little sort of decreased in the echoes. You get a faint line through here that is the mediastinum testis. You can see scrotal wall thickening, an enlarged and rounded right testis. Testicular echo texture is relatively hypoechoic and a bit more heterogeneous on the right than the left. You can even start to see on this B mode picture those sort of segments of the testis. Some important points here is that the ultrasound shouldn't delay a urological opinion if it's required, so that, you know, operative intervention can happen very quickly in a suspected torsion. The presence of testicular flow doesn't exclude torsion, because it's not uncommon for some flow to remain despite that ongoing torsion, because testicles can detorse and have hypervascular response as they reperfuse. In severe orchitis, you can get an infarction, and so there might be focal wedge-shaped or generalized sort of patches of hypoechogenicity. Where it's not immediately evident, the diagnosis is made more by correlating the history and the examination and sonographic findings, so that you have your index of suspicion from the history rather than just basing everything on the ultrasound. We've got an example here of epididymitis, and you can just see the hypervascularity in the tail of the epididymis and the thickened scrotal skin here as well. So the epididymal tail is the most effective, the most affected region, and you can see a hydrocele here, a reactive hydrocele, because of the epididymitis. Some other incidental findings, you might see a hydrocele. This is fluid around the testis. It should be simple, so it should be black fluid, anechoic, with no layering debris. They can be varying in size. I can remember one time scanning, it must have been 13 or 14-year-old guy, and it was like he had a cucumber. One side was so just disproportionately different in size to the other one, and the poor chap thought that that's what happened as you grew older, and I just can't understand like how it was hiding in his very baggy shorts, and that he hadn't thought to get it seen to sooner. But I guess teenage boys will be teenage boys. Often this is very painless enlargement of the testis. So the hydrocele is a fluid surrounding the testis, simple, anechoic, no layering, can be small, it can be large, but usually it's quite painless. Here's another bigger one. A bit of a hydrocele on both sides here. And the only way that you're going to be able to see this is using, you can see they've used the curved probe here. And that's just because the depth of this we're looking at, it's about 7 centimeters. So you wouldn't get very good pictures of that depth at 7 centimeters on the linear probe. Unfortunately, in this case, that fluid is such a lovely window to visualize the testis there. You might also have patients present with a lump on their epididymis, or a lump, and you know that epididymal cysts are quite a common finding. They can be very small, they can be bigger. They're usually very round, anechoic, should have posterior acoustic enhancement behind them. Here's another bigger one, and you can see this is quite contained but separate. So a hydrocele would sort of, it's got a little bit of fluid here, but a hydrocele would be around the whole testis, whereas this is quite contained around, sitting to the left of that testis. So now let's look at some quick troubleshooting. What are some of the common mistakes that you can make? Like I said at the beginning, use warm gel. If you've got cold gel and everything's a bit cold, the scrotal skin can thicken and it can get quite corrugated, and then the resolution underneath in the testis is not as good after with that dartos muscle in such good action here. So and it can artificially thicken the skin here. Well, not artificially, it's real, but it can make it look like it's thickened skin when it's not actually thickened skin because of pathology. It's thickened skin because you could do with some warm gel. The other common thing that can happen is that you're using a really poor grip on the probe. So if you're holding the probe up high because you don't want to get your hands dirty or whatever, you're not going to have control of the probe face and you'll slip off very, very easily. So anchor your hand position, use your Twining's fingers, number 4 and 5, should be resting on the patient. Now you should be getting gel on your hands here. We haven't got a glove on in this case, but I always perform a scrotal ultrasound with the glove on, and so getting your hands dirty shouldn't matter one little bit. So keep your probe grip down quite low and anchor your hand position. If you're having trouble staying still for that Doppler, the more of your arm that you can rest on something, the more stable your hand position is going to be. So bring the bed up a little and just let the patient know you're going to rest your arm on their leg. And rest from your elbow through to your wrist on the patient so that you can have the maximum control of the probe and the best chance of keeping the probe still. You don't want to push too hard. because the testicles are slippery little suckers and they'll slide about everywhere. And, you know, if you're pushing too hard, not only can it be uncomfortable, but just imagine it, guys, it's like a mammogram. Maybe not. But if you push too hard, they'll just spread away and move away from the probe. So again, it's really important to use feather-light touch. You want to just sort of balance the gel, balance the probe on the gel without sort of pushing or dispersing the gel out of the road. So you need to use lots of gel so that you can maintain contact, but just balance your probe on top of the gel without squashing them. You can scan too high. I have a bit of a story here. I'm a young sonographer, and I think I was very newly qualified, and I went in, you know, the history was that it was query an abdominal testicular mass. Was it cancer? And I'm scanning away, and I was like, oh, wow, that's a really odd looking mass. And I went and presented this to my radiologist, and I said, and it's really vascular. And he was just smiling, and he's trying not to laugh. And I'm like, what? Anyway, it turns out I was scanning too high, and I was scanning the base of the penis. And so it's very easy to do, especially as you head north looking for the epididymal head. So just make sure that you do check in and make sure that you're still on the scrotum and not scanning the base of the penis. If you can't see flow, the first thing you can do is make sure you have your scale optimized. Like I said before, you want to probably have that less than 7. So use a low flow setting. The next thing to do is to adjust your color gain. So if you pop the probe on and then wind your gain, use the gain button, it will be the B mode gain, and once the color is on, it now becomes the color gain. Wind that up until it flares and flashes at you, and then start winding it back until it just disappears. Now that's a bit of movement there. If you wind it down too much, and you can see here we're going to go down some more, same patient, but we've got the gain set too low, and all of a sudden we've got no flow in either testis. So you need to wind the gain up until it flares at you, and then start to wind it back until it just disappears with your scale setting here under 7. If you've got no flow, then sometimes it's hard on the point of care systems. I've used a couple for some of the pictures here, and you know, the color sensitivity on some of the point of care systems in that small parts thing, it's not their strongest point. So, you know, the machines are designed to do lovely echo or lovely abdomen imaging, but the color sensitivity on some of the linear probes of point of care systems can be a little bit tricky to get good pictures out of. So beware on young kids getting color flow, the vessels are even smaller. So that's going to be really difficult as well. You can see another example here, and it's a really fine line between having the gain set too high. I would say in this picture it is a little high because it's all aliasing here. So I'd wind the color gain down a little here so that it's proper, just red and blue. And like I mentioned before, pulse wave Doppler, I do not believe this to be the purview of the point of care testicular ultrasound scan. It's very hard to hold still. You have to make sure. It's really tricky to get a trace in a small vessel at the best of times, but unless you can hold the probe really still whilst you're optimizing your image, which is the next challenge. As soon as you've got your position, you go over here to fix the controls, and you know, then everything falls off and you lose your spot. So it's really tricky to do even on the fancy machines. So I would suggest that this is not part of the point of care exam.
So Anne, can I ask a question for you? Oh,
yeah.
Well, good timing. Hey, look at that. Yeah. Just on the point of the pulse wave Doppler. I'm so happy that you said you should probably, point of care people should probably try to stop doing it, because I tell you, I struggle with it. And I was just wondering how you guys do it. It is part of your normal formal scanning protocol, like if you order one, is that correct?
Yes, in some places I suggest it would be. For a lot of the time when I was scanning, we never used to do them. Some radiologists would want them, some don't. I think now it probably is part of the standard imaging scan, but it's bloody hard. Like it's really hard to keep everything still and to get a trace because it's such a small vessel.
Yes.
And two, because the testes, if you're balancing there, the testes just very subtly start sliding away from you.
Yep.
Little buggers, and so it is really, really challenging, even if you have lots of ultrasound skill.
Yeah, I have to admit, I did one today, and I spent the better part of 3 or 4 minutes, which is an eternity for an emergency room doctor, trying to get a nice low flow resistance pattern on my pulse wave Doppler. And to be honest with you, I didn't even need to do it because it wasn't going to add anything to what I already knew from all the other information I had. So I'm so happy you told us that.
Yeah, look, in a point of care setting, I wouldn't bother. And two, it really depends on your machine. Some of them are really going to struggle to get the sensitivity that you need. They're designed for cardiac applications and things like that with lots of flow. Even on high-end systems that are designed for point of care staff, for formal imaging, it's challenging. It's really challenging, even with the best of sensitivity.
I would surely highlight you mentioned the fact that not all machines are created equally, especially point of care machines. And I know within my own department, there's one machine that I would never try to use for testicular, and I'd go straight to my better machine because I couldn't get flow in either testicle with my lower end, one of my lower end machines.
Yeah. Well, and I would argue the point too for a formal scan. The times when I've seen orchitis or testicular torsion, the B mode imaging has said a lot to start with. There's a difference in size, the thickness, the echogenicity. There's other signs that are there, and if you put the color on, by the time you get to that point, if you're arguing between, is it just a little bit torsed or not? If they've still got pain clinically, how are you going to manage this? So it gets back to that clinical question. Does going after that to the nth degree, is that just a nice to have and someone's done some great research paper on it, or does it actually add to how you're going to clinically manage it? And I don't know that it gives you that much more than if you're just looking at the colour, and you can get colour well.
Yeah, I agree. I mean, I think looking at the whole big picture is really important, and it'd be interesting. I like to hear from my other colleagues around on the Zoom meet. I guess where and how does this fit into the point of care? Because I have to admit, a lot of people are not doing this application of point of care ultrasound. I think they're kind of scared off of it for some reason. But I personally think it's uniquely suited as a important point of care application because it's a time critical issue that we can very quickly sort out. You're usually talking about hyperemic versus no flow, so yes. High flow versus no flow. And acquiring the images, I know of course there's nuances and it's tricky, but it's not like there's air or bone in the way. I mean, you're gonna get an image. You're not gonna not find the testicle. I mean, so there's a lot of things to learn about, especially about how to set up your machine and everything else. But I don't know what other people think about what should we be doing this and whether or not it's being helpful and how it could be helpful. It'd be interesting to hear what other people think. How about you, Alan? You look good.
I think I do it. It's funny, you seem to get runs of them because I'm not in a massively busy ED. I've only worked in EDs in the last 10 years that are seeing 20 to 25,000 patients a year. So very elderly population most of the time. So you often get like 3 and then you don't get any for 2 or 3 months. But I sort of approach it a bit like you is I want to see clear evidence that on the symptomatic side, there's definitely increased flow, whether that's in the testicle or in the epididymis or both. I mean, because my thinking is if it's an untorted testis now that's got hyperemic, the pain should be getting better. So if I have a patient whose pain isn't getting better, and they've got clearly increased flow in the symptomatic side, I'm happy it's not a torsion. Because that's all I'm trying to work out. Is it an epididymoorchitis or a torsion? One question I had for Suean is it possible to have an untorting testis that only causes increased flow in the epididymis? I doubt that that would be the case. So if you saw it just in the epididymis, you could pretty much call it as epididymitis straight away, or non-torsion, couldn't you? But like I said, I'm looking at whether the patient's still got pain or not. I mean, I'd be interested in what everyone's practice is and what happens in their hospitals, but it's got to be determined by the hospital that you're in as well, because I have, in the last 10 years, the hospitals I work in, I have no capacity to take them to surgery on site. There's no urology. There's not even general surgery. In some hospitals, in pediatrics, you're not allowed to take them to surgery if you're not in a pediatric surgical hospital in Melbourne. These days, you have to transfer them to the 2 pediatric surgical centres if they're under, 12 years of age, because you can't get them done like in the old days by the general surgeons. So then you have to, it's a big issue. You have to transfer the patient. And if you're in a country hospital where I'm at the moment, and it's a 2-hour, 1.5 to 2 hour trip to a place, especially if it's pediatrics, where they've got to go to a pediatric center or a large regional base hospital where the general surgeon's prepared to do it, you have to make a call, and there's no one else around that you can call after hours. We just have office hour sonographers. So certainly in that setting, we need to learn how to do it if we're working in those places, because you can't just say, get in the car and your testicle will be fine once you get to the other side. And if it isn't a torsion, that's fine.
Yeah, you make a great point, Alan, about how.
And if you wait for an ambulance, it's another 4 or 6 hours. So you've got to put them in the car. If it's a kid, the parent's stressed out of their brain. Like all these things come into play.
Well, you made the point, obviously, the more austere environment you are, the more useful I think point-of-care ultrasound is. I'll be honest with you. Yeah, the other thing too, I'm sure you've probably thought of this, I don't know if you've done it, but you can, of course, make an attempt at manual detorsion, the open book technique, and probably go back and look and see if it's been successful. Of course, the pain should be resolved, but you could actually look to see if they actually have flow afterwards. And I think that might be interesting. Yeah.
I tried that. Right, have you tried doing that?
I've never had the opportunity to do it. I've tried detorsion before, but I've been in centers where I've had easy access to surgeons, and I've had general surgeons at regional EDs that were happy to take these to theater. Yeah.
I couldn't agree more that this is particularly suited to point of care insofar, like just scanning the testis. It's not particularly difficult to do. Like you don't have to adjust too much on the if you choose the right preset, you don't have to adjust too much. But I know that one case that stands out in my mind that I remember doing, the patient had come into the hospital at 11 o'clock with onset of pain at 8 o'clock that morning. I got called in at 11:30. We'd been there all day, had not heard of this case, and I got called in at 11:30 for a query torsion that had already had, by that stage, over 12 hours of pain. And for me, it was really frustrating because as soon as we exposed the area, you could see that there was a whole lot going on in his scrotum, and he had herniated bowel into his scrotum. But this 14-year-old kid lost their testicle, and it's something it takes 5 minutes. That could have happened right at the beginning and done something really positive for this patient. So it's relatively simple, with the caveat that, you're looking at the extremes. Is there no flow? Is there hyperflow? Is it orchitis? And there is some crossover, but I think it's particularly useful and an easy examination to perform.
Great.
Yeah, so to reinforce that, to follow on, if it's a marginal difference between the symptomatic testicle and the asymptomatic testicle, they've both got flow, I'm going to refer that patient. But at least I can sort of reassure the parents or the patient that you don't need to burn at 100 kilometers an hour for half an hour or 2 hours down the road, because you've still got flow to the testicle. So it is actually, somewhat useful to still do the scan, because, if you got, as I said, if you got really good flow in the symptomatic side, you're going to say it's epididymitis. If you've got no flow or clearly reduced flow, it's torsion. And if you've got somewhere in the middle, I refer those patients, but at least I know they're probably going to make it to the other end, and they're going to get a formal scan wherever I refer them to. Or if they can't get a formal scan, they're going to go to theatre for an exploration. But I'd be interested to hear what the other attendees do. What's the practice, and do they scan them? And if they do scan them, what do they do with the results?
Does anyone else want to turn on their microphone and
Yeah, just really quickly, just following up on that, the whole whirlpool sign. I'll be honest with you, Suean, I never really heard of that or seen it. I've heard people say that you could see the cord being twisted, but never heard of the whirlpool sign. Is that something we're going to pick up on, you think, and how common do you think it is?
That was a case that I have that I saw on Life in the Fast Lane, and I've grabbed those images off. I've heard of it too. I've not seen it in myself clinically.
Okay, fair enough.
But you know, if it's there, it's really obvious. It's kind of like, you know, interception. You get that lovely bagel sign, whatever, or the cinnamon scroll, and it's really obvious. But I don't know that they all just present so clearly.
One other thing that I found is you can find ectopic testicles. Like I found them in the inguinal canal before. And also I think you didn't really mention testicular abscess but I guess you can pick up on that too. One other incident, I don't know, Alan, if you found this too, but just incidentally seeing these hydroceles that are highly septated.
Yeah, I've seen them. Yeah. Almost like epididymis in the testicle.
Yes. Yeah, it looks crazy. Yeah.
I can't quote statistics for you, but I have seen a lot of those myself, and I don't understand the mechanism, but it's common enough.
The other thing I used to do, I probably sometimes occasionally forgot, is if I diagnose, I don't know what Suean would, I'd be interested in what Suean would recommend, but if I say someone's got an epididymal orchitis and I discharge them on antibiotics, I do still try to remember to ask them to get a formal ultrasound done, because I've read or heard of cases with someone's got an underlying malignancy or neoplasm that's led to them getting the epididymal orchitis or being a contributing factor, or maybe it sort of presents in a similar way to an epididymal orchitis. And, you know, if we're not really experts in necessarily picking up those subtle, there's many different neoplasms. I've seen pictures that can affect the testicle. So especially in the adult patients, I try to remember to ask them to get a formal ultrasound. Is that something that, you know, you think is reasonable, or you've heard of that being practiced?
Absolutely. I know that the neoplasms that I've seen have all stood out like the proverbials, given the topic with them. They've been really, really easy because it's the testis has such an even echo texture. Anything that's not even stands out. So, you know, it's really, really easy to see lumps and bumps on the testicle, or the microlithosis and things like that. But it's not unreasonable to just to check, even if it's checking that the epididymal orchitis is resolving and that the antibiotics are working. So it's certainly reasonable, I think, to have it followed up formally.
I personally haven't done all that in patients who I clinically suspect have epididymal orchitis, but maybe I should be. I don't know.
Well, is there any other questions or comments or questions for our next session in a month's time? Cool.
So Suean, in the chat, just looking at WeHow said that love the coaching session, would love to see some bowel ultrasound. So that's an idea.
That's a good idea. Yeah.
And so is
That's a good idea. Yeah, cool.
I think Alan's doing some appendicitis stuff with emugs.
I did it today with Martin Nikas, and I did one on bowel obstruction 2 or 3 months ago as well with Martin.
Oh wow!
So I'm happy to share some of those cases if you want.
Yeah, that'd be great, Alan. I'll get in touch, and we've got another month now until the next session. So same bat time, same bat station, 7:30, first Thursday of the month, and we'll meet again, I guess.
Thanks for organising it, Suean.
Great job preparing that. Really good. Cool. Excellent.
Don't be shy at showing your face. I don't mind seeing other faces.
I usually work Thursdays, but I've got Thursdays off now, so.
Oh, cool. All right, well, stay safe out there. Be well, everyone. Take care.
See you, Brian.
See you, Alan.
See you later.